Okay, thank you. I think that's the cue for everyone to sit down. So we're now going to have another round of digital stories, and I think we're really pleased to have our early career researchers and trainees presenting these. As before, they will play one after the other, and then subsequent to that, we'll invite them all on the stage for a Q&A. So without further ado, second round of digital stories.
Schools play a big role in young people's lives.
A place to learn, grow, and feel part of something.
They're also places where vital health research happens.
Research that can shape policies, improve well-being, and help build healthier futures.
But sometimes, setting up studies in schools can be challenging. And more, researchers are realising we might not be hearing from everyone.
To find out, our team of experts took a systematic look at the evidence.
We reviewed samples from NIHR-funded school-based health trials in the UK and compared them to national population data.
The good news? When it comes to binary gender, research samples represented the national population well.
But young people who weren't cisgender were rarely visible in the data.
Children and young people from global ethnic majorities were generally well represented at the start,
but were more likely to be lost as studies went on.
We also looked at geography. Although the devolved nations were overrepresented, the majority of research was conducted in England,
where just 1% of participants were from the north.
Many researchers made clear efforts to include young people with reduced socio-economic opportunities in their trials.
In some cases, this worked well.
Although in other studies, research participants were from wealthier backgrounds than the national average.
But other key details were often missing, like whether participants had special educational needs or disabilities,
spoke English as an additional language,
or had high levels of school absence.
These gaps matter because our research also found that these are the groups most likely to be excluded or drop out.
And if they're missing, our research can't reflect their needs or help improve their outcomes.
Whilst we know further research and nuanced understanding is needed, we hope our findings will help support more inclusive research in the future.
Because when everyone's included, the solutions we find are stronger, fairer, and built to last.
Ensuring a healthier,
wealthier
future for everyone.
What did you have for dinner yesterday? How much did it cost? There's a lot in the news about how expensive healthy eating is, but I think this is only one part of the story. A recent report by the House of Lords recognised that healthy home cooking is often an inaccessible and less affordable option for families, compared to less healthy and highly processed food. Over the past year, I've been exploring under-recognised costs associated with cooking meals at home. Throughout, I've been speaking to family, friends, colleagues and public involvement groups about the costs that they experience, and I'd like to share some thoughts. Raw produce is expensive, especially if it can't be eaten in time and goes to waste. There is a mental burden to planning meals. Deciding what to eat and what ingredients are required takes effort, as well as figuring out what needs to be bought, what might already be in the cupboards. There is a need to negotiate the preferences and dietary needs of those we live with. This isn't always easy and gets more tricky with different schedules. Petrol is a cost of going to the shops, as are other modes of transport, such as the time required for walking. For those who choose to shop online, delivery fees can be expensive. Cooking at home takes time. Batch cooking can be a strategy to reduce this, although not everyone has a big freezer. In fact, cooking at home is not possible in the first place without kitchen appliances and cooking equipment. There's also a gas or electricity cost associated with using these appliances. Cooking can be stressful, especially after a long day. It can also be physically challenging for some people who may have disabilities where standing for long periods may be difficult. Any home cooking results in a need to clean up. For most of us, this will mean washing up, as less than half of households have a dishwasher. With all these in mind, it's clear that the cost of cooking at home is not just about the price of food, and in fact, the full price tag is made up of so much more. I hope that my research will shed light on these wider costs so that we can find solutions which enable all of us to have the option of cooking healthy meals at home. I'll return to my initial questions. What did you have for dinner yesterday? How much did it cost?
I started this PhD with the idea that nature is good for pregnancy. To test that idea, I dug into papers that had already been published on the subject. I systematically reviewed them and found that mothers exposed to green and blue spaces reported better health outcomes for their newborn babies compared to those that weren't exposed to nature. The health conditions in question included babies being born premature or mothers experiencing mental illnesses during pregnancy. Beyond that, my PhD also includes a study of my own. I am now looking to see if I can observe a similar relationship in Wales. And as I inch closer to the end of my PhD, I find myself reflecting on the why of my work. I will let the science guide me, but so far the literature tells me that nature helps, especially among people living in deprived areas. So I know in the right hands, my work can contribute as evidence for all sorts of environmental initiatives to better someone's life. Before I started this PhD, I held the notion that good science is impersonal and clinical, but I found that in public health research, it's impossible to be completely detached. We deal with people and their health, their lives. So when I face my computer, I don't just see data points. I remember to notice the people and communities behind the numbers, the people I am trying to help. And selfishly, the other reason why I do this work is because I simply enjoy it. Throughout my PhD, I am constantly learning, and some days I feel so mentally stretched, my brain overheats like an old CPU. But I love that feeling, because that signals I have changed and grown for the better. I am not the same Rukun. So I do this work because I believe my research can matter to a lot of people. But I also do this work because I know it definitely matters to me.
This is the story of Pete, a teacher from Bradford. He's married and has 2 grown-up children. He has got out of a routine of eating healthily over the years, but is now looking to bring this back. With the urgency of climate change, Pete also wants to reduce his meat consumption to promote a sustainable future for his children. Pete is not the only one. Less than 1 in 10 UK adults meet all dietary guidelines, and not meeting the guidelines has strong links with increased risk of obesity and many other diseases. One day, Pete sees an advert in the local council's newsletter about a new wellbeing app. He gets excited and decides to sign up. The app includes recipes and information about the importance of a sustainable and healthy diet, alongside features to improve mental health. After using the app for about a month, he starts feeling more capable to cook nutritious dishes that are high in fibre and low in animal-sourced foods. He even feels he has more opportunities to eat healthily, as the app sends him reminders around when he eats his main meals. After about 2 months, his motivation has increased and he makes goals like meat-free Mondays. However, after 12 weeks, he starts to miss meat and struggles to find alternatives he enjoys. He feels empowered that the app has helped him think differently about food and starts to explore other ways he could improve his diet further. I'm Esther, and my PhD is on the role of smartphone apps to facilitate behaviour change towards more sustainable and healthier diets. Climate change is the biggest public health threat of the 21st century, and we need to find innovative ways to reach the UK's 25% meat reduction target by 2040. With the rise in technology, I see the potential of digital interventions to help kickstart healthy habits.
We often want to know how effective an intervention is, or which intervention from among a set of possible interventions is most effective. But public health interventions are complex. They are composed of multiple components. So we may instead ask which component of an intervention is most effective. In systematic reviews, network meta-analysis methods allow us to compare the effectiveness of multiple interventions, or multiple components, simultaneously. These are becoming popular techniques, and in every case an important step is to arrange the available evidence into a network, such as in these two examples. But it is not always as obvious as you might think to determine what your network should look like. For example, we could lump all the evidence from physical activity interventions together and compare them to dietary interventions. Or we could split apart all the different types of physical activity intervention and analyse them separately. Making these decisions affects the outcomes we observe in any analysis, and we call this process node making. My research has investigated the range of influences on node making by reviewing methods reported in systematic reviews across public health topics. We have built a typology of the elements involved in node making that highlights and categorises the breadth of potential influences on this important methodological step. Systematic reviewers planning network meta-analyses should be aware of these and may be able to use them to improve how they report their own node-making processes. In my own work, I'm going to take this knowledge forward as I further investigate ways of applying and developing these statistical methods to understand the effectiveness of components in public health interventions.
How does food insecurity impact Westminster residents? A community-based system dynamics approach. Food insecurity continues to rise in the UK. Despite multiple national and local policies designed to address poverty and health inequalities, rates are continuing to rise. Westminster is a borough with extreme health inequalities between wards, with some of the most deprived and affluent wards in the country. Church Street is located in the north of the borough. It's a highly diverse ward with the lowest average household income in Westminster, and almost 50% of the population is not in work due to a disability. Because of these risk factors, residents also experience high rates of food insecurity. So to better understand how food insecurity is impacting residents, we used a community-based system dynamics method. This is a participatory approach that brings people together. It recognizes that we all see and experience food insecurity differently, and that this is shaped by how the system is structured, but also by our own beliefs and assumptions. So through a group model building approach, I've been working with different voluntary charity services, community champions, and health and well-being workers, as well as different food aid and frontline workers to build shared models of how food insecurity actually exists in their area. Using a systems thinking approach, we're able to bring together different perspectives to understand how the system operates and how different factors are connected. This approach brings together people with lived and professional experience of food insecurity to co-create a shared understanding of the problem, which also includes how current policies and interventions may or may not be working. Through this approach, we are able to better understand the factors driving food insecurity in Church Street and Westminster. We've been able to map them into a causal loop diagram. This is a visual representation which highlights feedback loops and allows us to understand patterns and where problems worsen over time. But this process isn't just about mapping drivers. This approach centers lived experiences and fosters understanding. In turn, by better understanding how the system is connected and what is driving behavior, it helps communities and policymakers identify areas to take action and potential leverage points, which is what I'm continuing to do with these workshops over the next few months.
Okay, any questions from the floor for our digital stories? Paymene.
I'm sorry, I'm terrible with names, but the first presentation that was about schools, I just wondered what your thoughts were about the need for having representative samples in one study where maybe less than 5% of the population would be of the vulnerable groups or groups that you were talking about, versus over-representation of certain groups to make sure that we have that inclusivity, because they're quite different. And I'm assuming you were looking at the participants in each study.
Yes, so we looked at the participants in each study, but we also aggregated them together. So the figures that you saw in the video were for the aggregate of all the studies included in the review. But I think in terms of approach, context is really important, and making context-based decisions around inclusion, whether it's informed by the kind of questions that you're trying to answer, the current priorities and health needs in a setting. So it's a very difficult space. I think we need to keep having conversations about it because it is really important.
Okay, any other questions from the floor? We have one online. So for Bethany, has anything interesting come up about people who live alone?
Great question. Yeah, in a bit of work that I did around this, I tried to look at the proportional costs of, say, like time or delivery fees for a household of 1 versus a household of 4. Because if you're ordering food online, the proportional cost of that delivery fee is going to be much higher if you live alone. And in PPI, I had really interesting conversations, and people were saying if they lived alone, some people were less likely to kind of order food because takeaways or ordering food feels social. Other people felt like it's not worth cooking if you're living alone. So there's kind of like really interesting different perspectives. And I had somebody else actually say that they lived alone and all they did was cook, and they batch cooked, and that's what worked for them. So definitely there's some really interesting differences there, and I have looked into it, but yeah, it'd be interesting to talk more about that with you.
Thank you. Any other questions from the floor? Ashley.
A question for Esther. Esther, I wonder if you're talking about the digital apps. I wonder if you could maybe comment about, because obviously that's what an individual is using, sort of how that fits in with the wider policy perspective or the wider food availability, and particularly if you're thinking about people eating meat-free diets, and also thinking about ultra-processed food and meat alternates.
Yeah, very good question. I think it's something I've been grappling with since the start of my PhD, because obviously there's a big argument for population-based approaches rather than individual-based approaches. I think what I'm most interested in terms of the kind of translatable or generalizability of my PhD is thinking about food delivery apps and supermarket apps, and how the kind of behavior change components that I'm looking at in terms of recipes in the apps and kind of nutrition labeling and carbon labeling within the apps, how that can be translated to a more broad level app-based intervention approach, rather than something you have to sign up to yourself, but it's something that actually is more broad, and it's kind of nudged towards you in a kind of, supermarket or food delivery aspect. And for example, Lidl, some of the food actors are obviously much worse than others. And Lidl recently, so maybe some of you know that they have like the reward system, and they reward you with pastries. And they're thinking of changing that to more healthy alternatives, so give you like a nice box of strawberries, for example, instead. So I'm very up for that kind of thing.
That sounds like a reward system I would quite enjoy.
Yeah.
Pastries. Okay, we have time for one last question from the floor. Rona.
Hi, it's a question for Rukun, who's hiding behind you. It was just, you mentioned in your lovely film that you were doing a project of your own, and I wondered if you could just say a little bit about that.
Yes, thank you. Okay. I'm doing a retrospective longitudinal study. So my study population is looking at green-blue spaces' impact on maternal and neonatal health in Wales specifically. So I use administrative data from the SAIL data bank. Yes.
Okay, that's all we have time for. Another round of applause for our excellent presenters. And now it's time for the next round of presentations.
Thank you. So yesterday we heard about two of our research programs, and we're going to carry on with those. So the first one today is the Public Mental Health Program, and I'd like to welcome Judy Kidger, who's one of the program leads, and she'll tell us about our presenters. Thank you.
Thanks very much. Good morning, everyone. Is it morning? Is it still morning? It is still morning, just. Yes, I am very happy to introduce our Public Mental Health Programme. I'm Judy Kidger, one of the co-leads, along with Helen Dodd. Oh, I should change to the next slide. So I'm Judy Kidger, one of the co-leads, along with Helen Dodd. We also have Joyce Coker, Sophie Bacon and Gillian Samuel, all of whom are sitting together towards the front. So do grab any of them if you want to know more about the programme as a whole. For this presentation slot, I'm just going to take a few minutes to give a very brief overview stroke update of where we're up to with the programme. And we're going to then spend most of the time showcasing one of our projects, the WISH project, which I think has some interesting connections to the talk we heard yesterday from Chris Bonnell. So it's another school-based piece of work. And then we'll have some time for questions at the end. So just a reminder, or for those who haven't seen this before, this is our overarching aim. So to find effective and cost-effective ways to support mental health in all the settings that people live in across the life course. And we have 3 work streams that our projects fit within. So work stream 1 is looking at harnessing community assets to support mental health. And we have 2 studies in that work stream. So one is looking at digital assets and the other one is looking at informal volunteering. Then work stream 2 is looking at supporting at-risk populations, and we taking a systems view on that. And we have 2 projects within that work stream currently. So one is the 4S study, which is looking at supporting youth organisations around self-harm and suicide. And the other one is the support study, which is looking at supporting marginalised young people to access community assets. And then work stream 3, we've got one project at the minute, which is the one you're going to hear about in a moment. We also have another project which is under review, which is going to be looking at children not in school, hopefully, if it goes ahead. So this slide was just to speak to the theme around inclusion, just to give an idea about the different populations and communities that we've managed to involve in our research and that we are involving. And we were really pleased that Rowan also got a name check for the great work he's done in the 4S project to make sure that we have a diverse population there. So these are people that have taken part as research participants, but they've also taken part as public contributors and worked alongside us on designing the studies and carrying on looking at what we're finding. And also we've worked with a range of different practice partners who work with these populations. And by way of an example, the digital assets study has managed to recruit just under 400 participants across 29 different organisations, all supporting different populations with particular mental health needs. And then this slide, speaking to the point of it about innovation. So this shows the range of different methods that we've used for data collection and analysis, from very qualitative methods such as photo voice right through to working with data and existing data sets. To the left, you can see some of the creative outputs that we're beginning to produce from some of our projects. These are all available and will carry on becoming available on the SPHR website. And then to the right, just a reminder that we've embedded public involvement and engagement throughout at project level, but also at our programme level, brilliantly led by Gillian Samuel. And the owl that you see there is a sort of emblem for our public involvement charter, which is one of the pieces of work that Gillian's led on with some of our other public partners and our academic leads on the different work packages. So Gillian's had a display, and she'll carry, I think the display is still there, of the charter if anybody wants to know more or talk to Gillian about the process that was behind creating it. So just a final slide from me to invite you to stay connected with us. There's a couple of ways on here that you can do that. So we have a public mental health network that you can sign up to, and we produce a newsletter 4 times a year. And we're very happy, as well as people signing up to receive the newsletter, we're very happy to receive suggestions for content. If people want to write blogs for us or share events, etc., happy to hear from public and practice as well as academics. And then we also have our annual symposium. The next one coming up is online at the beginning of October. If you scan the QR code there, you'll be taken to an Eventbrite page to sign up. The focus is going to be very much sharing findings, and we really want to encourage practice partners to come along and talk about how our findings can have an impact in practice and policy. So I'm now going to hand over to the WISH project team, some of them. So we have Sarah, Joe and Davino who are going to be telling us more about what they've been finding. Thank you.
Hello everyone, I'm Sarah. And yeah, like Judy said, today I'm going to be talking about our project on the effectiveness and cost effectiveness of whole school interventions for student mental health, WISH for short, it's much easier. And thankfully, like Judy said, Chris Bonnell's talk and a lot of the talks that we've had already have really set the context for this talk, so that's great. And just to recognise that there's a huge team of people behind the results we're presenting today, and so thank you to all of them, and many of them in the room today. So I'm going to be talking about work package 1, which is more quantitative analysis. So we've essentially done this with three strands, 3 interventions. So at the top there is a teacher training classroom management programme, and this was investigating a trial led by Tamsin Ford and her colleagues a few years ago in the STARS trial, and what we're doing in this project is linking it with national pupil database to get that bit further along impact. There's some data delays on that one, so I'm not going to be talking about that today. Next down, we've got the mental health support teams, and specifically we're looking at those in Bradford. We're using the Born in Bradford and Age of Wonder data, which I'll talk about a little bit more. And then finally, we're working with a mental health charity who've got a whole school approach. We've been working closely with them, and they've kindly shared some data with us that we're working on. So, mental health support teams in Bradford, Born in Bradford, Age of Wonder data. Many of you will be quite familiar with this, but essentially, Born in Bradford is a data set of over 13,000 young people. Collects so much information, a lot about the children themselves, their families, lots of information. What we're interested for in terms of the main outcome is the Strengths and Difficulties questionnaire, which is ask questions about behaviour to do with kind of peer problems, emotional problems, conduct problems, hyperactivity. So the way the Born in Bradford works, there's sort of that's collected different sub-cohorts over time, but we're most interested in the two points that were, one point that was before the implementation of mental health support teams. So we collect data, we gather data that had been collected for that. The Age of Wonder is a project focused on secondary schools, particularly years 8 to 10. Again, the Strengths and Difficulty questionnaire was what we were interested in, and that was measured in year 9. And just to talk a bit about mental health support teams, you didn't see our poster this morning. They are kind of an adaptable intervention in schools that has essentially deliver evidence-based interventions for mild to moderate mental health. So there's one-to-one elements, there's whole school elements, there's lots of different schools essentially apply it in different ways. They support the senior mental leads in schools, and they give schools advice and liaise with external organisation, CAMs, charities, that sort of thing. So how did we work with this data? So first of all, what we had to do is find the people that were in the Born in Bradford study and the Age of Wonder study. That gave us an SDQ before mental health support teams were implemented and after or during. And then we linked that with school-based data so that we could say, we would know whether a pupil in that data set had been to a school with a mental health support team or not. And so while there's lots of people in Age of Wonder and Born in Bradford, the people that had information, all the things we were interested in, it was about a cohort of about 500 people. And then Holly Clark led the analysis on this, and she did inverse probability weighting, and that was to essentially weight the group so that those exposed and not exposed to mental health support teams were similar in certain characteristics. Finally, we fit regression models using mixed effect to account for clustering of schools, used calculated average treatment effect using G computation methods, and then used life sim modelling, which I'll talk a little bit about if we have time. So these are the results. These are the average treatment effects on the subscales of the SDQ. So for those of you not familiar with SDQ, you've got the 4 subscales at the top that each scored 0 to 10. The internalising is peer and emotional combined, the externalising is conduct and hyperactivity combined, and the total is the top 4 combined, so that's out of 40. So as you can see, if we look at the graph, generally, so a reduction in SDQ is a good thing. Generally, most things are going in the right direction, but particularly there was a significant improvement in conduct problems in those who had been to a school with a mental health support team compared to those who had not. So in this slide, we focused on subgroups, and we have done this for all subscores, but given time, we've just focused on SDQ conduct. Generally, overall, it is to say mostly going in the right direction. Some of these subgroups were quite small, so that's why there's those wide confidence intervals. But there are some differences. It does appear that the effect size for those who are less deprived is greater than those who are more deprived. So we had to combine IMD 3, 4, and 5 due to small numbers. And in this case, IMD 1 is the most deprived. So the next step was to use the life sim microsimulation health economic modelling, which was developed by our colleagues in York, Davies and Richard Cookson. So, in short, what the model does is it extrapolates from short-term changes in SDQ conduct into child and adolescent outcomes and adult outcomes. And those adult outcomes are health, social, economic, and well-being outcomes. So it covers a huge range. So when we did that, we put it through the model. I've just put some of the outcomes up on the left there. So there were improvements in unemployment, poverty, even premature mortality. These are absolute differences in percentages. They are small, but if you think about this as the potential to affect everyone in schools, that adds up to quite a big impact. In addition, the intervention of mental health support team is quite low cost, so averaged out over every pupil, it's about £45 per person. So, but when we look at all the estimated costs that LifeSim estimates, so that covers things like healthcare, related to benefit payments, income, the savings just over £100. So the savings of the intervention over the lifetime outweigh the cost of the intervention. For those of you who are interested in QALYs and incremental cost per QALY, which is what NICE used to make healthcare funding decisions, it was about £800 per QALY, which is a good thing. It's very likely to be deemed as cost effective. So the next steps in this part of the analysis is to use alternative regression models to represent non-linearity. Ollie Carlisle, who's in the room somewhere, he's actually been working on this already, so we're very close to doing that. Add in heterogeneity of treatment effect, so we can look at subgroups, but we want to have a little bit more individual level, and then do scenario and subgroup analysis. So we know subgroup in the short term, but we want to know how that kind of extrapolates over the longer term, knowing that some people have worse trajectories of health due to early disadvantage. So moving on to the work with the mental health charity and their whole school approach. So a bit of background, they offer a menu of different options to schools that they can take up on that includes individual one-to-one interventions, it includes parent interventions, it includes workshops, it's kind of interventions aimed at school culture, and they received some external funding to essentially put the whole package in 20 schools in the north of England. And that's the data that we're working with. What we're presenting on today is some of the results of the targeted one-to-one counselling, just because that's where we are with the data at the moment. And that lasts 4 to 5 months, but again, it's very adaptable depending on each individual, so there's a bit of a range. The challenge in this data was that there's no control group, so the charity believed in their intervention, and so they just wanted to see it in 20 schools. They weren't thinking about, let's compare it to schools that don't have that. So that's where we came in. So the first thing that we worked on, again led by Holly Clark, was the propensity score matching using Understanding Society, which is a cohort data set. So essentially almost trying to pull people out of that Understanding Society that look or seem similar to the people that we've got in the data set from the charity, and that would be based on age, gender, and baseline problems. So we were limited on that to what data we had, but trying to get a comparable group. Then same pattern again, same story, regression analysis, and using G computation methods to calculate average treatment effect. So this is the similar graph, different intervention. So again, mostly in the right direction, as you can see, and usually the conduct contrast, it goes in the opposite direction, although not significant. But in this time, there seemed to be a significant impact of the intervention on hyperactivity, very close to significant for internalising and for total difficulties. So a slightly different profile of effect, again, and also a quite different intervention in a way. So again, for subgroups, again, all generally in the right direction. What's worth noting here is we did note that people with, young people with worse problems at baseline seem to have the greatest improvement, which is positive, so we're looking into that a little bit more. And finally, the next steps on that is to, got some data on the whole school that we're working on as well. We're working with the charity who've got another data point they're going to provide us with any day. And then obviously work on the modelling. So we're going to work on working with the team in York to develop the model to be able to represent the wider profile of effect and not just SDQ conduct. So that was a bit of a whirlwind of everything that we've done doing work package 1 so far. And at this point, I'll hand over to Joe.
Thanks, Sarah. My name's Joe Hewlin. I'm a researcher at the University of Sheffield, working on Work Package 2. So the aim of Work Package 2 was to understand more about how or why whole school approaches to mental health work and under what circumstances. We aim to do this by undertaking a realist review of the literature on whole school approaches, then using the findings from this realist review and the findings from Work Package 1 to develop some logic models alongside stakeholders, which help provide some clear recommendations and guidance of implementation of whole school approaches. So a realist review differs from a traditional literature review in the sense that it tries to understand how interventions work, for whom, in what context and to what extent. So we included both qualitative and quantitative evidence in this review, and we included whole school approaches being delivered in both secondary school and primary schools, and we included any intervention which was described as being delivered as part of a whole school approach. So as Sarah mentioned, that could include targeted interventions such as one-to-one counselling. It could also include whole school assemblies, for example, which are used to raise awareness about mental health and well-being. It could also include peer support for staff and parental support as well. This next slide just talks through some of the steps which took place in the realist review. So we originally undertook a scope and review of the literature to try and identify some theory-rich evidence and pull out some theories about how a whole school intervention may work. At this stage, we're trying to unpick information about the context in which these interventions are being delivered, also try to understand the underlying mechanisms behind these interventions, and looking at how the context and mechanisms interact to lead to various outcomes. These are often described as context, mechanism, outcome configurations, or CMOCs. So we pulled out a list of these CMOCs from the original scoping of the evidence. We then presented these to our expert by experience panel and other stakeholders, and we use this feedback to refine our list, to refine some of the theories and then prioritise these. And the next step, which we're currently in the process of, is then searching for additional evidence to try and test these theories, so find evidence which supports or refutes some of the original theories we've identified. This next slide just talks about this process in a bit more detail. As you can see here, we identified around 18 articles from that original scoping search. From this, we identified over 300 different CMOCs or different theories about how whole school interventions work. And then we narrowed this down to around 18 or 19 CMOCs, which we prioritised with our stakeholders. We then used these CMOCs to produce this overarching framework. This is more for illustrative purposes, because I know you're not going to be able to read that, and we don't have time to go into this framework. But this was centred around 5 key mechanisms which may underlie how whole school approaches to mental health work. And on this next slide is just kind of a subsection of that overarching framework. So this next slide highlights the fact that trust may be an important mechanism in terms of how individuals access one-to-one support for their mental health. So if there's a lack of trust between students and teachers, then it's thought that students may be less willing to open up about their mental health needs, or less willing to disclose information about the support they require, and therefore less likely to access or engage with mental health support. And it's thought this may be influenced by students' awareness about the confidentiality of their mental health disclosures. So for example, if they're unsure about whether this information is being shared with other teachers or with their parents, they may be less willing to open up, and it may be eroding some of that trust which they've established. And this is particularly problematic, for example, if the root of some of the mental health issues could stem from the child's home environment as well. Another kind of contextual factor relating to trust is staff's capacity for pastoral care, being suggested by school teachers that they're unable to develop trusting relationships with students if they don't have the capacity to be able to deliver pastoral care. And again, this may be influenced by some wider contextual factors such as the school culture. So for example, whether the school prioritises academic performance over mental health and well-being, that may impact on staff's capacity to deliver pastoral care. So this is just one small part of a larger overarching framework. It is preliminary. We're going to search more evidence to try and unpack this further and try to support or refute this evidence. And that's what we'll be doing in the coming months. So we'll be searching for, doing some more targeted searches to get a more comprehensive view of the evidence available, and looking to refine some theories behind why whole school interventions work. We'll then use these findings to co-produce logic models based on this and Work Package 1 findings, and this will allow us to develop some clear, context-friendly implementation guidance about which aspects of school-wide interventions work, where they work, how and for whom. Okay, so that's just a very brief overview of Work Package 2. I'm going to hand to Davina now, who's going to talk a bit about how public involvement helped shape this work package.
So involvement was, how did PPIE inform Work Package 2? So the Expert by Experience panel was set up with members of the public, various members of the public, so young people, parents, teachers, carers, governors who were involved in schools. And they were involved in naming of the project. So we had a few different options that we presented to the group, and the group also presented names themselves. And this was done as a way to kind of kick off the group and also engage the members of the public, so they weren't just being given a study to take part in, rather than them also shaping the study from the beginning. The group were involved in also co-deciding the meeting schedule and how frequently they would be meeting and the length of the meetings. Again, another way to engage the group instead of the structure being decided for them, because we had, for example, teachers and governors who had working schedules that might not necessarily align with the project. We wanted to include their input in how this was decided. So yeah, the group was meeting every 3 months, and the ways of working for the group were all decided. So, for example, the ground rules and effective ways of working for the group were agreed collectively. The initial if-then leading theories developed from the realist review were presented to the EBE panel and in stakeholder workshops in which they provided feedback using their lived experience to prioritize and refine the theories that were presented. And also the EBE panel informed how the stakeholder workshops were going to be run. So stakeholder workshops were run separately, as they thought that it would be more effective that both the parents and teachers workshops and the young people's workshops were run separately, because there were different experiences with how people received whole school intervention. Thank you.
Thank you very much. So we have a few minutes for questions for anybody who presented on the wish. They're really interesting, by the way. Yes, please. Question over there.
Thank you. That's really interesting. I'm very interested in everything school-based mental health. I was just interested to know if there's definitely been some things coming out about the unhelpfulness or potential negative impacts of universal school-based mental health interventions. I think it also came out in the press yesterday. I wonder whether you think maybe, or how your work might feed into that, or if you found any context mechanism outcomes that may allude to any of that, or if you think it will help tease apart what might be helpful and what might be not helpful.
I'll take that one. I think it's important to say that from a universal interventions are kind of delivered as part of a whole school approach. A whole school approach more about kind of creating that ethos and culture which tries to develop and enhance well-being. In terms of harmful effects, I'm not aware of anything coming out yet with regards to that. So there's been nothing coming out of the CMOCs so far with regards to harmful effects, but that's something to bear in mind, I think, yeah.
Thank you. Any other questions, please, over there? Sorry, and I can see a second one there. Thank you.
Hi, thanks very much. That was fascinating. And it seems to me like, similar to Chris's talk yesterday, your work is contributing to the growing body of knowledge, showing how effective whole school interventions can be. And I wanted to ask Chris yesterday and didn't get around to it, so I'm asking you, how do you think we as researchers can contribute to a change in policy to help broaden the curriculum? It seems like there are now lots and lots of different bits of research showing the effectiveness. So how can we make that broader system level change? What should we as researchers be doing?
I guess I'll have to take that one as well. So it's a good question. I think from my perspective, it's understanding more about that the whole school approach does involve several different components and understanding those barriers to implementation relating to the different components and taking more of that realist approach, I think, which helps understand that not every intervention is being delivered in every school, and kind of a whole school approach is sometimes a wish list of different interventions which can be delivered, but it's not always feasible to do that. So from my perspective, I think it's taking that realist approach when you're talking about implementation and thinking about what works and where and for whom and what the barriers to implementation are, and trying to develop some clear guidance to help understand that.
Thank you. We have another question there.
Thanks. Before my question, just to come back on that point quickly. So DFE has recently set up a Science Advisory Council, which was set up by Russell Viner, Chief Scientific Advisor, well known to lots of people in SPHR. Chris Burnell and I and lots of other relevant people sit on it. So that is meant to be a conduit, a route through which people can influence policy. I think it's fair to say we haven't had much engagement within those meetings from the curriculum team yet, but certainly mental health teams and others are quite interested. So do get in touch with me, or if there's something specific, do write to Russell, and that might be a way through. My question was, well, yeah, first to echo others, it's such a topical area. It's a fantastic programme of work, so congratulations to all the team. My question was around the consistency of mental health support teams. So I think there's been quite a concern. There's a lot of different models of MHSTs across the country, and even within regions in our patch in North West London. And there's a lot of variation in the intensity, so the kind of the amount of funding per 100 pupils, whatever it might be. So I wondered, in that, the project in Work Package 1 that you presented, how much is it more consistent within that patch of Bradford, or how much was that an issue when you came to look at kind of dose response or differential models?
Yeah, I'll stand up so I can see. Yeah, so like I said, we worked with the cohort data, but we did work quite closely with the Born in Bradford team to get a bit more information on this. Things like how are the teams targeted, and we did have a bit of information on the kind of intensity, so how many hours were spent doing workshops, assemblies, one-to-one, but we were informed that the data probably wasn't that reliable. Understandably, it's not the priority of the people that are helping young people to record everything, and it's not quite that straightforward. So yeah, I definitely think it is something to think about, and Holly and I are on a ResNet project working with South Yorkshire mental health support teams, and the variation across region is really, really clear to see, and not necessarily in a negative way, but people, the leads use their own expertise and their own knowledge of the needs really of the area. So when we call it one intervention, what it really is, similar back to Joe's point, is more of a package, and perhaps delving into the different parts of that and what might be more appropriate in some schools than others is really important.
I'm just going to ask a follow-up on that, if I may, just before we come to Gillian. I wondered, were you looking at pre-mental health support worker and post, or was it that some schools did have them and some didn't? I didn't quite get that.
Yeah, so a bit of both. So we had a before and after point, and then some people had
them
and
some
didn't. Yeah.
And in that case, was there any indication of why some schools, I'm just thinking, were there differences in terms of the baseline levels in the schools that did and didn't have support workers?
Yeah, absolutely. So that's one of the reasons we did the weighting, was there were some differences. So I don't think there'd been necessarily, we didn't know whether there'd been a targeted, some schools were chosen. And I think part of it is how much the school engages. And so some of the things we noticed was the schools that were less likely to engage in mental health support teams were also less likely to sign up to Age of Wonder. But the Age of Wonder team have done an incredible job of broadening that. So got a lot more data now.
Really interesting. Thank you, Gillian.
Hi, very interesting presentation, and it's great to hear that the Public Advisory Group has been involved throughout the life of the project and meets regularly. I'm keen to know how the information that was being gathered was communicating to a group from a non-academic background, because what I've heard today perhaps could be quite baffling to people who aren't from that background. Was it challenging to be able to communicate to the public partners, the Public Advisory Group, all the information that was coming through? How did you go about it?
Yes, it was challenging. I think we're quite fortunate in the sense that some of our public involvement group were made up of people who were quite aware of the Bradford study and the Age of Wonder cohort, so have been involved in similar studies before. So we did have some people who kind of spent a long time developing skills in this area to be able to still have that lived experience, but still have a good understanding of particularly the work package 1 work. But in terms of helping communicate that, it's just patience and time. I think it was a lot of sessions where we were explaining the project and not trying to overwhelm our public partners. I think was really a key process in that, and that really helped us, I think, get across what we're trying to do and achieve.
I've got a question online, actually, for Davino, which is asking about involvement with focus groups with teachers and parents. Were there any? And if so, how did those go? How did you find them?
I might actually have to pass to Joe for that one, because I think that was the one I didn't attend.
You didn't? Okay, fair enough.
Thanks very much. What was the question again? Sorry.
It was whether there were any focus groups with teachers and parents, and if so, how did you find them?
Yes, there was. How do we find the dynamic, I guess, is the question.
I don't know, but I think so. That's how I would read it.
They worked really well. I think the difficulty we had was trying to find teachers to join the project. I think parents were perhaps more easy to engage with than teachers, and that maybe due to just the fact that teachers are particularly busy. But we didn't have any particular issues in running those workshops, and we found it a really useful experience with giving both an equal voice to be able to share both their experiences and how they deliver these interventions, and also parents' experience of their child being able to access this support.
Thank you very much. There's one more Slido question, but Rona, go first.
Thanks. Hi, I have a question about the inclusion criteria for the realist review. I noticed you said that you included any intervention that described itself as a whole school approach, and I wondered, did you make any judgment about whether or not actually you thought it was a whole school approach, and do you have a kind of underpinning concept of what you think a whole school approach looks like for the work?
Yeah. It's really difficult. So the several components, I guess a lot of it was based on the Department for Education guidance, which highlights these kind of 8 key components of a whole school approach. So we were looking to identify interventions which aligned to those 8 components, as I mentioned, targeted support. But we were only interested, one, if they were described as being delivered as a whole school approach, as you say. So I think if the research team said this is being delivered in a school which is delivering a whole school approach, we just had to take their word for that. But then we would include other studies which perhaps showed examples of perhaps multi-component approaches. So, for example, if there was a study which studied whole school assemblies and targeted support and parent support, we would then decide that this looks very much like a whole school approach. In terms of studies which describe themselves as a whole school approach, but there's no evidence that it is, we've not come across them yet, to be fair. It seems that there is supportive evidence within those studies which describe themselves as a whole school approach, that they are delivering a whole school approach.
There's one last question on Slido, a comment first to say that liked how you turned the CMO into if, then, leading to, and a question to say, can we ask how you came up with that? If you're able to.
I didn't come up with that, so I think that's quite. I think that's an established method. It is just that if then leading to statement does just help, particularly when you're working with stakeholders and public groups. I think phrasing it as an if this happens, then this happens, and then this leads to eventual outcome is a bit more understandable than kind of a context mechanism and outcome terminology.
Thank you. I can't see any other hands up, and I think we're almost, is there, sorry, one last question then, please. I think then we're up. Oops, sorry, 30 seconds. Very quick, I'm afraid.
I think my question is connected to Rona's, actually. So looking at the whole school approach, you mentioned that there were, it was quite heterogeneous, like what was included in a whole school approach. So I'd be really interested to know how looking at that quite heterogeneous group of interventions, how you decided what was effective and how you compared that across the sample.
Is that relating to work package 1 or?
Very long, so very
two?
short answer if you can.
I'm not sure I have a short answer. I think it's, I'm not sure I can answer the question fully. Is it work package 1?
I think that's probably where the kind of work packages come together. We've got the data that we have for work package 1 using the cohorts and the charity, but that's limited. There's 3 options, whereas the work package 2, like we come together regularly, and that helps us provide that context beyond what we're able to look at. So we will maybe be able to answer that in the future. We're just in the process of understanding really what works for who, and that's one of the next stages that we're doing, combining the 2 work packages. But thank you for your question.
Thank you to the team. Thank you for answering all the questions, and I'm sure there's more, but we'll move on if that's okay. So thanks again.
Okay, so we're moving towards the final session this morning, and we have a recorded presentation by Ashley Dalton, who is the Minister of Public Health. And we solicited questions from our Early Career Researcher Network, ResNet, which were put to Ashley Dalton, or at least through her private office, and that those questions have shaped her address to us. And just a little bit about Ashley Dalton, like our own Ashley. You can never have enough Ashleys. She is a Labour Member of Parliament for West Lancashire, and she's been so since February 2023. And she was appointed Parliamentary Under-Secretary of State for Public Health and Prevention at the Department of Health and Social Care in February 2025, so relatively recently. And she's previously served on the Labour front bench as Shadow Minister for Women and Equalities. So we're going to play the recording now, I think.
Hello everyone, my name's Ashley Dalton and I'm the Minister for Public Health. I hope you've been having a fantastic day so far. I want to begin by saying that health inequalities are one of my top priorities in this job, and this government can't get enough of experts. Research is vital for informing work to tackle health inequalities nationally and locally, and this school has a record to be proud of. You've been at the forefront of some groundbreaking studies on the biggest questions in public health, whether that's inequalities in rates of entry into children's social care or advertising for high fat, sugar and salty foods. This research makes a real difference and it improves the lives of families across our country. That's why I'm proud that we're supporting you and that here at the Department for Health and Social Care, we're doing our part as the largest funder of public health research in the UK through the NIHR. Now, I know that you are keen to hear from me on what this government is doing on health inequalities, child health and primary prevention. Through our health mission, we are focused on addressing the wider determinants of health to improve healthy life expectancy for all, while halving the gap in healthy life expectancy between different regions of England. So take just one example. Our investment in 30 health determinants research collaborations is helping local authorities to make the right calls on public health based on evidence, and we are already hearing great things about the progress they're making. We've also pledged to create the healthiest generation of children ever in Britain. The research you are doing through your Children, Young People and Families programme and other research themes will help us get that over the line. We know prevention is better and cheaper than cure. That's why our health mission sets out a plan to shift our NHS away from a model geared towards late diagnosis and treatment to one where the NHS focuses on prevention and more services are delivered in local communities. Just as we've taken action to protect our kids through the landmark tobacco and vapes bill, we will leave no stone unturned when it comes to addressing harms like obesity, physical inactivity, harmful alcohol consumption and poor air quality. We're building a fairer, healthier Britain, and each and every one of you has a key role to play. Your research can provide the insights we need into what is working and how we can tackle the inequalities that shape someone's life from the moment they are born. Remember that the annual scientific meeting isn't a talking shop. The discussions you have today can shape the future of public health for years to come. Keep building connections with practitioners, decision makers and communities so that your research can continue to have an impact on the health of our nation. I hope you enjoy the rest of the day, and I know that you'll go from strength to strength from here.